We have welcome to our weekly Zoom conference. Is the Zoom chat webinar conducted by the neurovascular team at Lenox Hill Hospital, Lenox Hill Neurosurgery. Today we have Dr. Serulle and myself, and Flora Salman is part of our team as well. She's running the conference. And this is going to be featured through Zoom as well as through Instagram Live. Dr. Ellis and Dr. Langer, I know that they had a major surgery that was going to happen today, so they might not be done yet. So to start, I will start chatting about some new information that was published earlier this week. However, please ask questions or interrupt through the chat. You can ask any questions there and we will answer as good as we can. There was a paper published by the Journal of American Medical Association Neurology earlier this week, in which there were 3 hospitals in Wuhan that collected all their information in regards to neurologic manifestations of COVID-19. And they included a total of 214 patients. 59% of them had non-severe presentations of COVID, and 41% of them presented with severe infection according to the respiratory status. That's how people have been measuring who has a severe infection versus non-severe. So 41% of them ended up requiring admission to the intensive care unit and or getting intubated or dying. And in that cohort of 214 patients, it was documented that 36.4% of them had some type of neurological manifestation, more than 1/3 of these patients. And in some of them, the initial presentation was a neurological manifestation, more than cough or fever or any other of the common symptoms that people relate COVID-19 to. It was also noticed that these people that presented initially with neurological manifestations ended up being some of the most severely affected by the virus. The severe infection incidence was higher in the older population, as well as in the people that had hypertension, high blood pressure, which we know goes along with the risk factors for cerebrovascular disease and or coronary artery disease. Also noticed was that in those that had more severe infection, they had a higher incidence of stroke. 6% of, or in the people that had a higher, more severe infection, 6% of them had a stroke, versus the ones that only had mild symptoms of COVID-19, only 1% of them had a stroke, so 6 to 1%. Impaired level of consciousness, 15% of the people with severe manifestations had impaired level of consciousness, meaning lethargy or confusion or stupors, obtundation, versus 2% of the group that had mild symptoms. And in this group, they also looked at skeletal muscle injury. They did this because sometimes some type of peripheral neurological diseases present with muscle weakness or muscle aches, and 19% of the people that had severe neurological disease had some type of muscle injury, versus 5% of the people that had mild COVID-19 had some type of muscle involvement. Dr. Serulle, any opinions on these findings, on the increase of neurologic manifestations and presentations in people with COVID-19 that had severe presentations versus the ones that had mild presentations had lower incidence of neurological manifestations?
Yeah, you're making very good points. And it seems to be that is one of the few evidence-based publications that we have so far addressing neurological conditions. I think it is not surprising in a way that those patients that have these neurological manifestations are those patients where presumably that that inflammatory response is taking place. To that end, at the same time, I think that we need more evidence because we have a lot of anecdotal evidence pointing to either more, neurological cases, less neurological cases. In terms of the vascular pathology, there was one interesting paper that came out in the last week, published in the journal European Neurology, titled "The Baffling Case of Ischemic Stroke Disappearance from the Casualty Department in the COVID-19 Era." Is published by an Italian group where they publish their own data in their own medical center. That is one of the biggest center in Milan, which is the epicenter, one of the epicenters, at least in Europe, of COVID-19. And they saw a drastic decrease of ischemic stroke, which is something that others have echoed as well here in the US. So I think that the evidence is still to be seen. What's going to be the final impact that COVID is going to have in neurological disease and in what pertains to us in ischemic stroke. But I think that that new paper that came out from this Italian group, it's very interesting because it's suggesting that there's some, in their case at least, there was a definitive decrease in ischemic stroke in the months since the COVID epidemic started.
Yeah, like you mentioned, a lot of this is anecdotal. Many centers are just presenting their data. It's very challenging to study this prospectively or with in a coherent way, so that we have real results that we can cite. For example, this study from Wuhan it was retrospective and it was
Right.
observational, and it was lacking a lot of the key neuroimaging tests that we typically perform for these patients. Whenever someone comes to the hospital with stroke-like symptoms, they get CTs, CTA or CAT scan with contrast. They also get an MRI, an MRA of the brain and neck, a cerebral angiography, and many of these tests are being avoided for obvious reasons in order to decrease the risk of transmission of the virus to patients as well as to healthcare providers. So it creates a big challenge. You mentioned before the inflammatory cascade as one of the potential answers for the findings in the study from Wuhan. And it is believed that the elevated pro-inflammatory cytokines in the blood may be the cause also for this skeletal muscle damage that was seen in this study, not just for the incidence of stroke in the sickest patients. And when they look back at SARS, which is another coronavirus using the same ACE2 receptor, they did not find any side effects in the skeletal muscle in these patients.
Right.
So it was a very different type of result back then. Going back to your point of some centers describing a lower incidence of strokes in their hospitals, we have seen that in our hospital, although we have to say it may be because some people are not coming to the hospital,
Right.
Despite having a stroke. I have seen several patients in the telehealth visits that we perform, in which we connect with patients while they're at home, and we communicate like this through video conferencing, and they I'm evaluating them, and after they had a stroke, and when they had the stroke symptoms, they didn't go to the emergency room. They didn't call 911. They waited to see if the symptoms were going to get better or worse, and then a few days later, they ended up calling their primary care doctor, who did a telemedicine consultation, ordered an MRI, and then referred to me. So we might be missing a lot of opportunities to treat people in the acute setting, in order to revascularize the arteries and in order to improve their symptoms. Other sites have, anecdotally again, reported that they're seeing a higher incidence of large vessel occlusions that require mechanical thrombectomy. So they are, right now we're doing, collecting the evidence as a health system. Actually, Dr. D'Amico, who's on the line, he's collecting the evidence of Northwell Health as to see if there is any stronger suggestion of either increase or lower incidence of strokes in patients with COVID-19. And we're doing an effort as a New York City-wide network as well.
I think, Dr. Ortiz, going back to what you said about patients not coming to the clinic sometimes or to the hospital, there's some say that there's been an increase in deaths at home in the state of New York, in particularly affecting New York City. So I wouldn't be surprised that some of these deaths are patients who are probably elderly, who've had ischemic events. They don't initially go to the doctor because of, you know, being afraid, probably because of the coronavirus epidemic. And then these are the patients who are deteriorating at home and possibly passing away at home as well. So I think that's one possibility. And as I said, I think, you know, we have to wait and look at the actual data and see what the data is going to show us. But I just wanted to mention one more thing about this paper from Milan that was just published. They were asking themselves the question about why would we see less of the large vessel occlusion strokes during COVID, which was their experience in Milan. And they have two possible, they mentioned two hypotheses in their case. They mentioned the fact that we know there's an increase in interleukin-6 in COVID patients, and they mentioned the fact that there's some experimental evidence that probably IL-6 has some protective effects in acute infarct, and the fact that a lot of these patients with COVID have thrombocytopenia, and they raise the possibility as well whether thrombocytopenia could have a somewhat protective effect as well in these patients from developing LVOs or large vessel occlusion. So I think some things to keep in our head, and as we go and try to understand further how COVID and coronavirus impacts neurological disease and neurovascular disease.
Dr. Langer was able to join us, so welcome to the conversation. And we have been discussing recent literature suggesting that there might be a significant number of patients with COVID-19 that do have neurological manifestations. Up to, in a recent study from Wuhan, 36.4% of patients with COVID-19 had some type of neurological symptom, and especially in the ones that had a more severe infection according to their respiratory status of either requiring ICU care, intubated, and or dying from their respiratory complications. And this was demonstrated in stroke, impaired level of consciousness, as well as skeletal muscle injury. Dr. Langer, in the ICUs at Lenox Hill hospitals and at the Jacob Javits Center, which I know you've been working there, have you seen this type of presentation in your patients?
There's basically two things going on. One is there's definitely neurological symptomatology, but there may be a variety of issues. One is that the patients that have the worst manifestation is often the sickest. So we're really struggling with imaging and with therapy. So if you have a very sick patient on dialysis who has ARDS type picture, who's not waking up, we're not really scanning enough patients yet just because of the volume of patients like that. So we probably don't, and we're not LPing them. You know, there are really 4 ways that COVID patients develop a neurological issue, actually 5. One is stroke, which is some sort of hypercoagulable state. The D-dimers go exceeding very, very high, over 1,500 in fact, when we start to see hypercoagulability, which can lead to stroke for sure. They get demyelinating disease, they seize, but the most concerning are toxic anoxic encephalopathy, which we are definitely seeing a fair amount of. They're just patients that have been off of their sedatives, their narcotics for days, yet don't wake up, and the scans are negative. So this is likely a blood-brain barrier disruption from cytotoxic storm, or a combination of cytotoxic injury, anoxic injury, sepsis that's leaving these patients encephalopathic. That's probably somewhat recoverable potentially. And then the other one is a direct encephalitis. The drug virus has been shown to spread through direct neural invasion through the olfactory tract and potentially into the brainstem through the parasympathetic and sympathetic system into the lung epithelial cells. Oddly enough, one of the things we are seeing is patients that have saturations that are in like the high 80s and don't feel short of breath. They're like breathing, and I think that might be a baroreceptor issue at the brainstem. There's definitely an element of that that's pretty common. Patients can have really mild symptoms. I mean, the presentation can often be loss of sense of smell and taste early in the course of the illness, and that likely is from olfactory tract involvement through direct nasal extension, as opposed to patients who develop late stage neurological symptomatology, which obviously is much more severe and impactful. But it's there. We'll probably know a lot more about it once the hospitals start to decant a little bit and we have more time to study patients radiographically. We just haven't had the bandwidth to move nurses and doctors to the magnet. And frankly, the CAT scans have not been that revealing that I've seen so far. I've probably seen 5 or 6. None of them have been really that impressive. So, it remains to be seen. There's no question there's a lot of it out there, and it'll be interesting to see what comes of it.
One of the topics that everybody's talking about now on April 15 is about the path to recovery. And in New York State, we're still seeing a very high number of people dying from COVID-19. We had approximately 750 people die in the past 24 hours. However, the number of patients going into the hospital, requiring intubation or requiring ICU care has dropped tremendously over the past several days. Now comes the question about when is it going to be safe for us to go out and start going back to a new normal. Some experts suggest that until we have a readily accessible way to test people, we're not safe. Others think that until there's a cure or vaccine, it will not be safe. Some people think that we can go back to a new normal in May. Some people think that it will take 18 months from now. Dr. Serulle, what's your opinion on these thoughts?
I think there's a lot of controversy here for sure. And I don't think we exactly know when it's going to be completely safe to go out. I think there are several theories. It seems from what we're seeing in our medical system, we have somewhat hit a peak in terms of admissions and in terms of new infections coming in the system. Certainly, we have a lot of severely ill patients still in our hospitals. But I think we just have to wait and see how these things are going to evolve over time, because I think it's very hard to predict right now when it would be potentially safe to go out.
Dr. Langer, any opinions?
Well, there's a terrific review of this by Scott Gottlieb and his group from the American Enterprise Institute, which is worth reading. First of all, we are likely going to see continued social distancing until the fall. The next phase will be when we see 14 consecutive days of decreased admissions is when you'll likely see a consideration of reopening. Because that's the time of the duration of infection to conclusion of the infection. So if you continue to see dropping rates of infection for 14 days, then theoretically you've got a control on the human-to-human transmission, and you'll likely see talk and discussion about sort of quote-unquote reopening society. Which Ohio is doing something really interesting. They're taking a sample of, I think, a few thousand people, and they're just basically doing random testing just to see what the asymptomatic positivity rate is, which is really critically important, because if the rate is very, very high, then obviously you have to be more careful about reopening. If the rate is lower, then you basically can use surveillance testing when people get symptoms to determine what the frequency of infection is. But if you talk to Hong Kong, who's about 2 months ahead of us, large city, certainly New York, if you're talking about when New York's going to reopen, if you look what's happening in Hong Kong, which has similar population density and their infection rate was actually lower than New York City just because they actually social distance way before the infection got as severe as it did in New York. I think that what will happen is you'll have restaurants reopening. Everyone will wear masks. Restaurants will have a limited number of patients required that'll be allowed to go in. No tables larger than 4. There'll be no bars, no clubs, no gyms. Will be no movie theaters, no sporting events until we develop therapeutics. And phase 3 is therapeutics, not necessarily vaccine, but therapeutics, meaning some drug combination or a drug that not only limits the spread but improves the outcome, limiting the people that go on to mechanical ventilation, go on to respiratory failure. People will develop respiratory distress. The key is preventing respiratory failure. From what I understand, there's a trial of a triple combination of drugs consisting of 2 HIV medicines, ribavirin and Kaletra, along with beta interferon, that seems to be working really well. That may be the answer, something like that. In other words, we're not going to have a vaccine till the earliest next summer. And at that, even when it comes out, it's going to be primarily for healthcare workers and people in hospitals first. So to widely vaccinate we have to have 60 to 70% antibody positivity to prevent another epidemic, at least in the United States. And to get that number vaccinated is a public health issue that's likely going to take at least a year and a half to 2 years. So I think in general, I think we ought to look forward to somewhat of a reopening, probably sometime end of May, early June of New York City. There'll be a rolling opening through the rest of the country. Undoubtedly, Republican and red states will likely open up before blue states for a variety of reasons. We'll see social distancing in effect, basically penalties for not wearing masks in public, limited number of people in restaurants, and people return to work. Hospitals are not going to allow visitors in hospitals for at least the next year. There'll be antibody testing for healthcare providers, as well as COVID testing for patients. We can't let families in because you can't test families for antibodies and COVID. It's just too onerous. So our whole environment is going to be very different. I think that what we want to get to is phase 3 with therapeutics and with a vaccine. I would look to see, I would imagine we should see decent therapeutics by the end of this year, early 2022, and probably return to normalcy, the way we used to live our lives, which will probably never be the same, sometime at the end of 2022 is the likely with the vaccine. So it's super interesting. The vaccine itself is amazing. I actually was lucky enough as an undergraduate medical student and resident to work with the scientists who basically developed the basis for the current RNA vaccine, which has to do with a certain type of nucleic acid difference between straightforward mRNA and what the vaccines are. All the vaccines are doing is they're identifying an mRNA sequence for the capsid protein of the virus, what's called the S protein, which is the surface protein of the virus that binds the ACE inhibitor. And they've sequenced that protein, and they've created an mRNA sequence with this, what's called a pseudouridine. It's basically a modified form of one of the nucleic acids that basically allows this mRNA not to activate the immune system, but churn out S1 protein, and they're going to get essentially an IgM-IgG reaction to a unique protein, which is the S1 capsular protein. If this happens, they've already tested it, they're dosing it. This is the fastest that a vaccine's ever been developed in a year and a half. So it's a really remarkable science. So, I think we have to get used to the new normal. I mean, we're going to see a very different environment. We all need to be antibody tested for obvious reasons. But in some ways, more will be asked of us, and we'll have new challenges, and we have to just be creative and take advantage of these things and work hard to create an environment for ourselves where we can be effective.
I've been demoralized for the past 5 minutes since you said 2022. But that's reality.
Yeah, I mean, you'll probably get a vaccine yourself by next summer, by 2021. The trouble with vaccines are that they probably only last 3 to 6 months, because it's like a flu vaccine. That's every year, and they're the survey if the healthcare providers will get them first, they'll give them the high risk patients next. Nursing homes, the elderly. But to inoculate the whole population is going to take a long time, and they have to make them available to, private family practice doctors, minute clinics, Rite Aid, Duane Reade. So there's a lot to look forward to, but by the same token, I think we're going to live in a different way. A friend of mine's a restaurateur, and what likely we'll see is there's going to be a lot of availability in Manhattan. They'll probably end up centralizing the kitchens. So you'll have one sort of building will house a large kitchen, and they'll have a limited menu at like 20 or 30 sites. So you'll have Chinese, a Thai, Mexican, and they'll be creative, but the food will be made as centralized to save money, and then it'll be distributed to essentially to heat it up locally. You'll probably see a lot more outdoor eating, takeout. And who knows? Americans are incredible, and especially New Yorkers are innovative and creative. And I'm sure we're going to see some amazing ways that people not get around it, but use this to create new environments. So you could think about, eating above people, or outdoors, climbing stairs and lattices, outdoor eating with heaters that allow you to be, have an experience that might be kind of cool. And I'm sure we'll figure out a way to survive and thrive. It's going to take some time.
Talking about returning to the new normal, it's important to mention to the people that are listening that today we do perform any type of neurosurgical emergency at Lenox Hill, anything that has to do with brain aneurysm that ruptured, a brain aneurysm that is causing weakness or paralysis of one eye, a stroke or blockage of an artery that needs mechanical thrombectomy, surgery for a large tumor, for example, the case that is being performed today, a large tumor that is causing blindness, and we will, we're taking care of those right now. At the same time, we are already starting a process to take care of less emergent cases, so some semi-emergent or urgent cases, someone with an incidental brain aneurysm that has not caused bleeding yet, but to prevent the bleeding, someone with narrowing in an artery, the carotid artery, that requires an endarterectomy, open surgery, or a stent to prevent a stroke from happening. These are all cases that, yes, we are right now planning to start doing the upcoming days and weeks. So these are conversations that we're having as a team to ensure the safety of the patients, their family members, and the healthcare providers.
Can I show you something, Raf?
Go ahead.
These are are some graphs of two things. One, here's stroke. Can you see my screen?
Yep.
These are the door to TPA. These are the number of stroke cases have dropped by 39% between February and March. And more importantly, look at STEMI. Like acute MI, there have been 0 acute MIs
Wow.
in March. I mean, there's just there's also been a 22% decrease in the chief complaint of chest pain from February to March. So there's something amok. I don't exactly, no one can tell us what this actually is. But I think, one of the possibilities that's been, I kind of would like to believe is that there's some teleologic, evolutionary, some of that's clearly people's not coming to the hospitals or, going to small, who knows, or places that have available. There's definitely a lack of that, but this is happening all over the country. And I think there may be like an aspect of when you have a crisis of this magnitude, to think about if you were a hunter-gatherer population or, Neanderthal man, and there was in your society, there was this massive, earthquake or something. And if you were left behind, if you were sick or injured, you died. And it's very possible that there's some sort of genetic reaction that happens when you have these tremendous stresses to society, where you have some hormonal change that cardiovascular disease, doesn't manifest. It's certainly a possibility. And the other is just that people are dying at home, or they're just not coming to the hospital, which also probably has a lot to do with it. There's a question about how hospitals are handling the round of residents who just graduated medical school. I do know what's going on. I don't know if you guys want to comment on that, Raf or Yafell.
Well, obviously, I know that right now the medical students graduated early. And that's something that has been done all over the world, of students finishing earlier to become part of the workforce and help during the pandemic. There was a lot of debate on what was the right thing to do. Should students, since they haven't learned what was part of the curriculum yet, should the graduation be delayed? Or should they graduate early so that they become part of the workforce and help during these super busy times? And the decision was the latter one, which I think is very appropriate. And same thing then happens to residency programs. Dr. Langer, I don't know if you want to give your opinion on residents.
I mean, look, I think what they're done is the medical students who've graduated are now moving into their own hospital systems. Luckily, some of them are staying here at Northwell or NYU at NYU. They're usually 30 to 40% of residents stay in their own institution. So it's, starting a little bit early. I think there's something lost there. I mean, as much as I think it's an important thing for them, I think some of my happiest times were my time between my medical school and residency, where I had a month to, do something unique before I, essentially grew up. So this is a unique moment for these young doctors that I think being part of this, to be quite honest, is a privilege. I think that it's a world historic event, and I think that there is some risk, but in general, while you lose something in coming to work early, I think there's a huge benefit to being able to go and use your skills. They can't do that much. They're doing some of the same types of things that we might do when they were medical students. As far as the residents that are finishing early, they're not. I mean, the residents are just being put to work and redeployed. Our residents are, about half of them are still doing some neurosurgery. The truth is, though, that the residents being redeployed is sometimes a little bit harder. You have to kind of fill a niche. And since they're not attendings, it's harder for them to go and be as aggressive and find a niche for themselves and go fulfill it like we have done in our department. But pretty much everybody's being asked to do work who's capable outside of their bandwidth. And it's been, to me, it's been in some ways one of the most gratifying experiences I've had, in all honesty. so far. It's been sad and I think depressing and anxiety provoking, and you know, you have your kids and your family, you worry about these things, but I think the experience of going through this has been very gratifying in many ways, and it will be for them too.
So on another topic, important to remind people that we are, yes, seeing people in telehealth. We have our address is lenoxhillneurosurgery.doxy.me. I just entered it in the chat. It's lenoxhillnsgy.doxy.me. And we have a virtual waiting room where patients can log in and you can connect with any of us, any of the doctors. Dr. Serulle, what has been your experience so far using the virtual telehealth?
It's been great. Interestingly, patients love it. Every patient I've seen by telehealth, in every case, they have been very thankful that we're using this. They feel there's a good connection between them and us, and that they feel that, you know, they're getting all their concerns and all their questions answered. So I think it's been a great experience. It's been very, very helpful in these times when patients are feeling worried about coming to the hospital. So I think it's great overall.
Yes, and it is the new normal. This is how we're interacting with people now. Dr. Langer, we're also using Playback Health to create a video content for patients. As I understand, also it can be used now for telehealth as well.
I mean, it's basically more like a mobile form of telehealth. We have a desktop version as well, so you can use it to essentially use the same app to make movies and videos and communicate synchronously as well. So it's going to be a brand brave new world that we're entering, and I think we've all grown more comfortable with it. I mean, even this conference, we never would do this way.
Correct.
Yet, you know, the truth is that it's great. I mean, once you get used to seeing yourself on the freaking screen, and you get more comfortable, and then you become yourself. It's an acceleration of, you know, this is what we're experiencing when you adopt technology. There's a chasm between the early adopters and like the crazies and kind of general adoption. And that chasm is based on this. It's like, if you're not forced to use it, or there's not a real reason to use it, there's always a reason not to use it, you know, or to get over that little hump with the software or the click or how many clicks, you know. And so because we were forced to use it, you know, we got through this learning curve so quickly about how to set these things up that it's a no-brainer now, and we actually enjoy it. I mean, we'll never go back. I don't think there's a reason to have face-to-face conferences anymore. I'm going to give my 4th grand rounds tomorrow. I'm giving one on Friday and one on Monday without getting out of my chair. I'm not flying and wasting money on hotel rooms and fancy dinners, and you can even meet with the residents afterwards. I mean, you can pretty much do whatever you want with this, and it's an extraordinary change. It really is. It's all going to make us better family members, better partners. There's no reason to be going all over the darn place anymore, and this is going to be super impactful. You know, I think we'll all be changing. So I'm excited about the future, really excited. By the way, there's a question you should answer, Rafa. You are Rafa.
Yeah. But before that, when is the telehealth for Playback available?
It's open.
It's right now. Okay.
On Apple.
On Apple.
Droid, we're working with Google to get an early release on the Android, but Apple works. So if you have a patient, the way it would work is you can actually call the patient without them even being in the app. You can actually do a FaceTime through the app. You can start the patient, begin to make content, you know, movies, documents, access them through the app, do a FaceTime with them through a through the web app or the mobile, and then you can actually sign them up at the conclusion of the telehealth consult. So it's a really slick way of using Playback, and we'll train you guys how to do that. How to do that in the next couple of days. But I'm going to try it on a patient tomorrow, I think. And if we may be able to get off Doxy completely. So we'll see.
Okay. So yeah, we had a question here that said that someone had a stroke in December. Main question is likelihood of recurring stroke if medications and blood pressure under control. Do TIAs happen anyway? So the number one thing to take into consideration is why did the stroke happen to begin with? Whenever someone has a stroke, it's because of either high blood pressure, like it's mentioned in the question, and or diabetes, high cholesterol, smoking, narrowing of the arteries in the neck, narrowing of the arteries in the brain, or a source coming from somewhere else in the body, like the heart, in which people, if they have irregular heartbeats and or a clot in the heart after having a heart attack, can go to the brain. So depending on what caused the stroke, the treatment has to be tailored to that. If it was a small vessel stroke, meaning that the heart was normal, that the artery in the neck was normal, that the main arteries in the brain were normal, and but they did see a stroke on an MRI and the person had symptoms from a stroke, then we have to assume that it was related more to high blood pressure or other comorbidities or risk factors like diabetes and high cholesterol. So in that case, the best we can do is medications and lifestyle modifications. If someone had a stroke because of high blood pressure, yes, they need to take their blood pressure medicine and take some type of blood thinner, either aspirin or Plavix or Brilinta. Those are the three most common ones that we're using these days. But if the stroke was related to something else, so diabetes, high cholesterol, some other cause, obviously that had to be addressed. TIAs, transient ischemic attacks, they should not be happening. That's not a normal sequela after a stroke. TIAs are premonitions of a bigger stroke happening potentially one day. So if someone is having, TIAs are transient ischemic attacks or mini strokes, that's the other way people call them, which are someone experiences stroke symptoms, however, they return back to normal within seconds or minutes. So if someone is having TIAs, that's an emergency. They do need neurological workup, even during COVID times, including an MRI, including an echocardiogram to look at the heart, including checking the arteries in the neck with an ultrasound or CTA or MRA, and to figure out if there's any other risk factor that can be treated in order to prevent a stroke. Anything to add, Dr. Serulle?
The only thing I was going to add was that I think even in COVID times, if you have any concern that you may have a stroke, feel you need to reach out to your physician, to the hospital, go to the ED if you feel like you're having any focal symptoms. But I think it's very important that people stay aware that a stroke is a very important condition, and that there are many ways of reaching out to us in these days, and people should be reaching out.
Okay. Something that I wanted to let people know is on June, you're welcome. On June 5th, we're going to have a major international conference. Lenox Hill Neurosurgeons is hosting a COVID-19 conference, and how it relates not just to neurosurgery, but also to everything else, to research and to the experiences that the initial experience that people had in Wuhan. We're going to have a speaker from Wuhan. We're going to have a speaker from Hong Kong. We're going to have a speaker from Germany, and as well as the several lecturers from Lenox Hill Hospital and Northwell Health. We'll be talking about the impact in neurosurgery, in medicine, critical care medicine, in the healthcare system as a whole, as well as in the global economy. So that's June 5th, and we're going to be sending invites in the upcoming weeks for people to participate. I don't see any other questions. Anything else, Dr. Langer, that you would like to add?
I mean, I think that I look forward to these meetings. Sorry, I missed the first one. I got to say that I just hope, you know, after 9/11, I remember everybody was nice to each other for about a month, and then we all kind of, everyone sort of got worse. To the point that I think this almost was like this thing to me is like a giant punishment for some of the behavior of our culture. But I can just tell you a story that happened to me that I'll carry this forever. And also I think it is the truth of the way I'm just going to try to live the rest of my life. And that is that we were short ventilators last week, and I tried everything I could to get a bunch of plastic surgeons to donate their ventilators to Lenox Hill Hospital at the last minute. And it was around the same time that Cuomo said he was going to seize all the ventilators in 24 hours and distribute them himself. And I panicked. I was like, I worked so hard, and I wanted to make sure we get them to Lenox, and it looked like we were going to be fighting with the governor to get ventilators here. And by Sunday, Dan Bakers, our CMO, said to me, Dave, you know, I think we're going to do what we can to get them to Lenox, but remember that no matter where these things go, they're going to help somebody. And I had like my brain just like, I had this like epiphany, like, he's right. Like, no matter where the ventilator goes, whether it's a patient here or to Elmhurst or to Columbia, it doesn't matter. And that, since that moment, I kind of totally took on it's really impacted me a lot. It's one of the reasons why I'm at the went to the Javits Center. You want to do things that are valuable and that doesn't make a difference who's getting credit for it. It doesn't make a difference who you're taking care of. And I think that I think that our department will hopefully reflect that going forward, and that we serve as an example. We were always doing well beforehand, and we've always been unique, even the way we treat one another and these conferences. But I hope we are even better by an order of magnitude, and we all think that way as a department, as a hospital, as a society. This is in some ways a very fortunate thing to have happened, in my opinion. As painful as it's been, as sad and as destructive to our livelihoods, our finances, all the things that we used to take for granted. But let it make us better, and I really look forward to seeing if we can do that, because that's the ultimate challenge. And I appreciate Rafi getting these things going, and I hope we have more people that will come listen to us pontificate for an hour on a Wednesday afternoon.
Talking about things that are better these days, I was reading about the pollution around the world and how this can impact in a positive way climate change.
Well, hopefully they can measure some decrease in temperature.
Yes.
Did you see? This is God's punishment.
Okay, so this was great. Looking forward to next week. We'll be here again.
All right.
Thanks, Raf.
Okay.
Thank you, Flora.
Thanks, everyone. That was great.
Thank you.
Bye now.